Okay. Um, if you have any problems with the sound and pictures after this, let me know. So good morning, everyone. Thanks for coming. So we're going to do this session about complications for ERCP. I'm going to record the session so we can put it onto the YouTube website that I've made. And the good thing about that is that you can access the teaching video whenever you need, okay? I'm going to share my screen now, so just let me know if that doesn't work. Can you guys see the PowerPoint presentation?
Yes.
Brilliant. So it's about ERCP complications and how to manage them. Because you guys will obviously get these patients back in recovery. 9 out of 10 times they're going to be all right, but 1 in 10 times things can go a bit wrong. And I think this is very important, especially for nurses that are relatively new to ERCP, to get a good idea about what you have to do. Now, ERCP, this is a very famous phrase from one of the first people who first did ERCP. It's 1% frustration, 2% radiation, 3% inspiration, 94 perspiration. And what that means is you need to work very hard and get a lot of experience with ERCP to do it properly and to recognize complications. But this is more to do for the procedure. But I think it's just trying to say to you, the more you are involved with ERCPs, the more you know how to manage them better. Now, there are a few important principles for both doctors and nurses to know. If you want to have safe ERCP, you have to plan, you have to prepare, and you have to monitor. Planning is all about making sure you have the correct patient. So you have to make sure that you've done all the right screenings to make sure this is a suitable patient. You have to plan the right equipment. You have to plan the right staffing. If you get that right, the chances of something going wrong is much less. You prepare in the same way. And most importantly, after and during the procedure, you monitor. You monitor if anything is going wrong, and you monitor the patient after they come back. If you follow these principles in general, it's less likely things will go wrong, or you will pick up things that go wrong early and know what to do. Now, these are the most common complications: pancreatitis, hemorrhage, perforation, infection, stent problems, and cardiopulmonary, such as heart issues and breathing issues due to sedation and things like that. Now, the best way to remember things is really learning from mistakes. So, like I said, plan, prepare, and monitor. The other thing that I found was most useful for nurses, particularly, when the patient is back in recovery and you want to get a rough idea whether you're likely to have any problems like pain or infection or patient being unwell, definitely try to get good information about what happened during the ERCP. Was it a straightforward, easy ERCP? Was it difficult? Could they actually do the procedure? Perhaps if you had a patient with a large stone and the endoscopist couldn't get it out, then the chances of the patient having a fever or blood pressure being low or septic after the procedure is going to be higher. So nurses can help themselves by really finding out what happened during the procedure. And one way to do that obviously is to read the report. I mean, there might be a lot of medical jargon, but the things you want to look for is, was the procedure successful? Did it take a long time? Was the papilla difficult to cannulate? Was there any bleeding? Was the procedure very long? And if you look for these things, it helps you predict if there's likely going to be a problem when the patient is back in recovery. Obviously, the other thing is you've got to escalate to the clinician promptly once you pick up something is going a bit fishy. This is a system that one of the guys at America uses, which I think is quite useful. 5 R's. You recognize when there's a problem. For example, if you don't know how to recognize a problem, then you can't really respond very well. And what I mean by recognize is, for example, are you familiar with how to recognize on an ERCP when you have a perforation on the image? Do you recognize the signs that someone has a perforation clinically? Same with pancreatitis. Do you notice the low blood pressure, the pain? You've got to recognize the most common complications. Secondly, after that, don't panic. Respond, not react. So the best way to respond is to recognize the complications, know what they are normally for ERCP, and then have kind of a game plan for each one. Reach out. Don't try to do it on your own. Call for help. Revisit normally means after you sort out a problem, the endoscopist might have to do a repeat ERCP to see what's happened. And repent is a lot about the endoscopists too. The biggest reason for complaints is when endoscopists don't come back to see their patients each day. But the first three parts are very crucial for doctors and nurses. ERCP pancreatitis. The most common factors that are associated with post-ERCP pancreatitis is a younger age, if you're female, if you have conditions like sphincter aortic dysfunction, difficult cannulation. So these things you can pick up on the report. Think about the high risk of pancreatitis in these patients when they come back. The basics are the same. For most people, you have some pain. So a little bit of painkiller is okay. But if the pain is very severe, you obviously need to speak to a clinician. We check amylase. A small rise in amylase doesn't mean you have pancreatitis. If your amylase goes up by 3 to 4 times, that's more suggestive of pancreatitis. Fluids, painkillers, bowel rest. Obviously, in the more severe cases, if they're admitted, you have antibiotic surgery, endoscopic drainage. So from a nurse perspective, you just need to look for these risk factors and be a bit more vigilant. A bit of pain is fine, painkillers, but if it's a much deep-seated pain, it's not really going away, call a clinician, maybe do an amylase and standard bloods. If the amylase is, more than 4 times, that's more suggestive of a ERCP pancreatitis. Okay. For bleeding, it's the same thing as well. There's what you do during the procedure, and you can have bleeding after the procedure. It's the same 5 hours. You've got to recognize it, but then how you respond depends with the endoscopist. When they're doing the cutting, it's very easy. Oh my God, there's bleeding. I've got to stop the cutting. But normally you have to cut through the blood vessel so you can actually treat it. You've got to put, sometimes people put a guide wire and a balloon to tamponade it, or they use the adrenaline or cautery. Okay. And similar principles when you have delayed bleeding. So here's a little test for you. So I got 2 ERCP pictures. Which is the abnormal picture? Left or right?
Right.
Right. Who said right? Okay. So can you guys tell me what's wrong with the picture on the right?
Left is okay because you can't see the scope.
There's something very wrong with the picture on the right, but what do you think it is? Describe what you think you can see. Anyone?
There's some shadows there which we don't know what they are.
Good. So this is why it's important you can recognize a perforation, because if you all do the ERCP and you don't recognize it on the picture, that's where your trouble is, because you don't respond quickly. Look at this line just right here where the shadow is. This is a perforation. You have air. So this is a massive free air perforation from a sphincterotomy. So as you see, if you guys can't recognize it, that's the danger. And when you're doing the procedure, so remember the 5 R's, recognize what the problem is. And this is why, it's good to do this teaching, so you can see this is a very clear-cut perforation, because you see no air here, and suddenly you see this very clear differentiation between the lungs and the under the diaphragm. Does that make sense? Okay, so recognize. So for me, the key lessons, you have to have a system to respond, like the 5 R's. If you're aware of the most common complications and you know how to recognize them, that's half the battle won. And then the second part is learning how to respond. Now, what we'll do is I'm just going to quickly do one of the videos for the complication, which should be about 5 minutes or so. And then we can finish off with any questions and answers, okay? Can you hear the sound? That's the other thing to check.
And also from my side, welcome to this session on complications.
Can you hear the video sound? Hmm? Sorry, I can't hear you. You can hear the sound. Okay.
ERCP and ERS. My name is Thorsten Beiner. I'm working at the Evangelisches Krankenhaus in Düsseldorf, Germany, and I will present to you two more cases of complications related to ERCP. These are my disclosures. So this is the first case. As you can see, we have here a large lateral spreading adenoma of the papilla, also involving a large area of the adjacent duodenum. And as you can see, we have also a small periampullary diverticulum, what makes papillectomy even more difficult in this case. This is the image during the procedure. As you can see, we could nicely resect the mucosa from the papilla and the surrounding tissue. You can clearly identify here the pancreatic orifice. Already a guide wire was inserted into the pancreatic duct. This might be the biliary orifice. There's no need for cannulation here. And you can see the surrounding tissue has been resected, and this used to be the area where the diverticulum was or is located. Next image. This is the final result after papillectomy. Nicely resection of the adenoma, including the papillary part, and a straight 5 French stent, 5 centimeter in length, has been implanted. So unfortunately, the patient developed fever and abdominal pain about 24 hours after the procedure, and also an elevation of the cholestatic markers in the blood test was noted, and the patient developed a new jaundice. And so we rescheduled the patient for endoscopy, and this is what we saw. You can see the pancreatic stent is still in place. The guide wire was already inserted into the bile duct. You can nicely see the surrounding tissue, no major bleeding. But I would like to show you what happened to this patient. Please focus on this area. This has been the area of the diverticulum. And as you can see, we have here some disruption of the muscle fibers in the depth below the submucosa. And I would like to show you a short video sequence. You can see the biliary guide wire is in place, and please recognize this. Please recognize this area here around the papilla, 9 to 10 o'clock position. So first we do the biliary sphincterotomy until all the bile comes out of the CBD, out of the orifice. And as we have a disruption of the muscle fibers here, that will be a small perforation next to the papilla. After that, we implant a fully covered self-expandable metal stent. With this, both the jaundice, the cholangitis, and also the perforation was well treated, and the patient recovered without with an uneventful outcome.
Okay, so the reason I put that up is just to show you that's another potential complications infection. It still goes to the same thing, so you have to recognize if there's a problem. Diverticulums at the duodenum can cause a lot of problems with blockage and obstruction or perforation. So that's probably another one to remember. If they say there's a diverticulum in the report and it was tricky, think about whether there could be a problem. So you've got to recognize the signs that tell you there could be issues. Respond. So you don't panic. You go in, you do what you need to do, whether that's putting a small sphincterotomy to ease the obstruction, putting in a stent. Particularly for bleeders, the worst thing that could happen is you react, you panic basically. You've really, if you really think about it, there is a way to do it. You just got to remember it at the time. And the best way to do that is to rehearse in your head a system, whether it's 5 hours or whatever you want. Okay. So hopefully that gives you a bit of an overview about the different complications about ERCP. Now we got a minute or two if you want to ask any questions to me. So go ahead. Anybody?
It's not really a question, Dr. Fong. I just want to share so that they can relate it to JAG as well. JAG requirement is for each facility to have 150 cases per year. And for each endoscopy is a minimum of 75, if I remember correct, 75 a year. So it's just to say that obviously we're meeting that minimum requirement.
That's good. And like you said, that just means that both nurses and endoscopists have enough experience to hopefully do this properly. But the more procedures you do, the more complications you'll see from time to time. So my key messages for you is know what the complications of ERCP are, so you can recognize them and you know how to escalate, have a system. Okay.
Sorry, I've got something as well to ask Dr. Fong. In some hospitals, they tend to do ERCPs under GA, all of them. Do you think it's a good idea, or because personally I feel most ERCP patients, they're at comfort when they're under GA. I don't know, is it something which the trust think doing, or?
I think that's a very good point, Margaret. There is some data to show that those done under GA seem to be better sometimes, not always. It depends on the endoscopist and their skill level. But for example, if I remember correctly, all ERCPs at King's are done under general anesthetic or enhanced sedation. At Guy's St. Thomas's Hospital, they reserve the more complicated ones for enhanced sedation, and they do the basic ones under sedation. So there is some difference. I think it's nice to have the option of enhanced sedation for moderate level to significant level complicated ERCPs, but a lot of basic ones can probably still be done under sedation. So it's one of those that you decide as a department, but you can see there is some differences even in the big centers about what you do.
Thank you.
Okay.
Yes,
Anyone else?
I just want to support about what you say regarding the report. It is very important after it's been done to print it out and then to read out in case if there's anything else that needs to be done. For example, if a patient needs PTCA or if the patient needs to be admitted afterwards, you have all the information that maybe you didn't know about. So just to support what you said, especially to the new nurses.
Absolutely. I think it's a responsibility of both the nurse that is bringing the patient back and the nurses receiving them in recovery. Communicate the really important bits of information, like where there's problems during the procedure and what you need to do later, because these are the parts that's the weak link sometimes where things get missed and then you don't escalate quickly.
Another thing, I have requested to be added to the business plan as E-arm so that we can hopefully in the future perform our ERCPs in the unit.
That sounds great.
Yeah, and I think at the moment it's being supported. I got feedbacks that, yeah.
Okay, brilliant. Okay, guys. Well, in that case, I'll probably draw the session to a close. Good luck for today. I will upload this video onto our, and as you know, we have a new YouTube website for endoscopy education. So all the videos we do over time will go onto the website, so you can look at them at your own leisure if you need to refresh. Okay.
Thank you.
Thank you.
You're welcome. All the best.
Thank you.